everyone. My name is Sahako Terani. I'm a development fellow at the QSite Institute. It's my pleasure to introduce our next speaker for today, Karmen Williams. Karmen is an assistant professor in online Masters of Science in the Population Health Informatics program and the Health Policy and Management Department at City University of New York. She completed a postdoctoral fellowship in Public and Population Health Informatics at Indiana University and Regenstrief Institute. Her research focused on systemic informatics integration projects such as patient-centered data homes and dental medical record integration. Dr. Williams is also actively involved in the American Medical Informatics Association, where she is the director of For Your Informatics, a podcast that explores the limitless world of medical informatics. Thank you so much for being with us, Karmen. Please take it away whenever you're ready.
Okay, thank you. Hello. Hopefully you all can hear me okay.
Yep, sounds great.
Wonderful, thank you. Thank you so much. And I was just thinking with you reading that introduction, I'm probably not going to talk about any of that today, but that's okay. I'm very excited to be with you all today and talk a little bit. And I have a doctorate in public health. I have some business background. I'm also in sociology, and so I'll talk a little bit about that today. And I just want to talk about diversifying health equity through the participation in community science. And so offering a potential solution to some of our health equity data issues. The first thing I like to say, Bell Hooks, who recently passed, and I heard our keynote speaker speak about her this morning, and learning like love is mutual. And so I'm so appreciative for spaces like this where we can come together and talk and learn mutually. And so I have learned so much from you all. A lot of the things I'm going to talk about today are really based off of what Dr. Ayisi, I hope I'm saying your name right, just talked about. So I'm just so happy to be moving forward with that background. As an overview for my presentation today, I'm going to talk a little bit about some of the challenges with health data, some of the challenges in health and how data has shown those challenges, how it's come out to the forefront. And this particular meme talks about your sample sizes are small, your standard deviations are high, your conclusions mean nothing, and you should feel bad. And I'm not saying you should feel bad. I'm saying we need to do something about that, though. Also, one of my favorite shows is Forensic Files, and so I'm kind of have this idea of health data files, just talking about some of the great things that have come out of knowing the data. And it'll be really brief because I don't want to go over my time. And then I'm going to talk about this idea of how we can empower ourselves to create our own health data. So just as background, I want to talk a little bit about some of the issues, and I know several people have already talked about this, which is wonderful to see how we have this intersection of environmental health and just different things that come along which affect our health and ways that we can start to begin to have the conversation to affect health in different communities. One of the things this author, Richard Rothstein, talks about the color of law, and it talks about the redlining issue that's happened in I'll say all the states in the United States. This particular author talks about how specifically in Bronx and how there was a rating basically on where people should live. In a lot of cases, like a place like Nashville, who has both Meharry Medical College on one part of the city, and then just 2 streets over is Vanderbilt. And it's such a huge difference with the highway going through the Black community where Meharry Medical College is. And then in Vanderbilt, it's just a huge difference in health disparities. It's a difference in a couple of streets. It's a huge difference. So we see this in several cities and just how this rating system has really affected the health of a lot of individuals. So you see this crossover of policy, you see this crossover of environment, even the idea that in these areas, certain businesses are allowed in this area versus not being allowed in the other areas that were not redlined. So we see this racial residential segregation that has happened in the United States. One example I gave was in the Bronx, and so you see that it reinforces several different types of racism. And so you see with this kind of thing, just different effects of health that come out of this. And this has been happening for years, unfortunately still happening. And we see this a lot with the housing sector, which we are seeing from the data that a lot of things come out of just having secure housing, having food in areas in which you live and not having to take transportation to go get a healthy meal. So we see this often. And so, like I said, with the history of redlining, you have like the Great Depression, which provided these like homeowner financing. In the 1930s, they had this risk category. And so A being the best, B still desirable, C definitely declining areas, and D hazardous, meaning that don't move there. Negroes now live there. They're gradually taking up the area. They're moving in, and so you have this color coding of different real estate. You'll see there were things on maps that basically said, this is where the Negroes and Spanish and Puerto Rican are coming into. It's very unstable. It's a lot going on in this area. We really should think about what goes on here. We see this, and this, like I said, that was in the 1930s, and we see these lasting implications, such as obesity prevalence. You can see in the different categories just how high this actually is in those areas, and outside of those areas, and how you see this disinvestment of like good resources and things like access to, like I was saying, healthy foods and safe spaces, clean streets, and even quality housing, having the different, not having like associations that kind of keep up with what's going on in the housing. You even see like the asthma epidemic. You can see the differences in the red areas and where there's highways and things going through these areas where you see a high number of things like asthma among children and those who are considered economically strained and things like that. So we see these different drivers even in our healthcare system. There's different ways we know that social determinants of health and how that impacts the cost of health. In these particular cases, it's less likely, like in these areas where you have this high concentration of where people have been redlined and pushed to a specific area politically, all kind of different economic ways. And so you see that particular area, you can see where they lack access to care. They lack access to like a primary care physician. And then you see maybe they will go into the emergency room more often when something comes up. And so you see these costs are a lot higher in these areas, impacting the way. So you already are having financial strains, your income. Even if you have the income, you can still see that there are some issues in trying to gain access to these other communities. And so we continue to see those different things based on racism, based on just different things, the system that is set up basically to push certain groups of people into areas that will cause strain. And especially we see that affecting their health. So thinking about social determinants of health equity, when we think about this, we can think about how that's connected and what this conference is about, connected to justice and social justice and criminal justice and how all of these things affect this. You can see how employment or the lack thereof would have a direct correlation with criminal justice, or earnings and education would have a direct correlation with employment, and then employment would have direct correlation with housing. And so you see how all of these things kind of interact and can really affect how we see equity in our societies. And I'm trying to get right through this, so hopefully if you have questions, we can get to them shortly. Additionally, another challenge we see, the myth about physical racial differences were used to justify slavery and are still believed by doctors today. There have been quite a few studies, even recently. This was in the New York Times. There's one that was just, and I forgot, I want to say Washington Post, I could have that wrong, but talking about how doctors are putting different things. We see like negative, more negative terminology and wording used in patients' files and patients' records, and differences you see among Blacks and whites, and how that language is even framed and it could be the exact same kind of situations, exact same, I'm trying to think of the word, conditions, but for some reason, we still see these kind of things coming through. You see this racist mindset or racism, and it's built into the system. So it's definitely a challenge that we're still trying to get over in a lot of ways. I was thinking about this, and this article came out in 2019, And so this particular study, thinking about this, that was right around the time that COVID came out. And so it's kind of the thing, do you think this has changed, or that this issue changed in a matter of months with the onset of COVID-19? And I would say absolutely not. And so when you think about COVID-19 and this big thing that we went through, or that we're still going through, that there, we saw all of these articles. This came out in April of 2020, so almost to 2 years since then. And there was this big shortage of everything. And so you could just imagine in this situation, not only are you having a strain on the resources, and this is just basic resources, food and different things you need for your household. If people who have a lot of money to get these things were unable to get it, what do you think that does for people who already had a strain on their situations economically? We think about this particular article talks about what health spending issues do we have to, think about. We had to think about medical, economic, social. It was a shock to the system. You saw more food insecurities. You saw things like there was a surge in the demand in the supply chain, but then you have the shortage of even medicines and basic medicines, and you had people going, and there was exposure of the essential workers and things like that, putting themselves in harm's way. One particular person commented, and this is Cece Connolly of the Alliance of Community Health Plans, talked about the outbreak was the latest reminder that as a nation, we have not invested sufficient money into social needs and inequities, a stronger safety net of housing, transportation, food support, et cetera, would have positioned many to have better weathered this storm. And so it just really exacerbated some of the issues that we have with health equity. Even globally, we definitely saw this as a shock that really brought out the inequities that are going on with human rights. And this particular chief talked about just some of the things that were going on, specifically looking at even with vaccine inequities, who was able to get the vaccine, and it was really not an equal opportunity virus. This particular chief mentioned that it really showed many inequities that came out during this time. And then there's the idea of looking at all this data. How are we able to leverage this to improve the outcomes, or improve if this were to happen again? What do we do with this to improve even our healthcare system now, knowing that we have the data from this thing? So what do we do? We also, going back to the redlining, we saw definitely a disproportionate impact of COVID-19 pandemic. You saw that we had high rates in these particular neighborhoods. You saw rent burden households, and specifically in people of color. Most of these people in these areas were service workers, and you can see just the colors, like the more bold the colors are, the deeper the colors, that's where the area was hit the hardest. And so you even see that the same with the vaccination rollout. You can see the same pattern of seeing a disparity, and it's so clear in the data that this is going on. And so how do we fix this? Another challenge I want to bring out is the idea that over time, so many things have happened that have really, even when we get into science, and I guess what I mean by this, like we get into it, we're becoming a part of science. Things like our investments or our innovations are taken. I would say in these three cases, as an example, the creator of Jack Daniel's whiskey recipe was actually Mears Green, who was, and this is his son in the picture, but he was actually the creator of the recipe. And now Jack Daniel's does, I shouldn't say admit, but they actually put out that they do recognize that he was the creator of that. Even with the inventor of Monopoly, that particular invention the credit was given to someone else. And then even with the invention of the rape kit, Marty Goodard, it was actually taken by the chief of the police of Chicago at that time as his creation. And so looking at all of these things that kind of happen with underrepresented populations, even attempting to get in science, we still have this barrier of when we actually do create, there are a lot of times they get taken. And then beyond that, We could think of things like the syphilis study and different tests that have been done on people who were in vulnerable situations and how they were just done badly, So who wants to get involved in science knowing all of that backstory? But we see the effects of that today. We see that women and underrepresented minorities in science are very low. We see there was a study in Google and Gallup did how, and sorry, I don't want to go there first. I want to go to the women and minority in tech. But we see how there's even, once you get in, again, how you have this alienation of female recruits. It usually has this, they talked about in this particular sociology study about how the presentations and the masculine language, even in the websites, and how women in STEM make $16,000 less than males, even compared to $14,000 less if you're Black or Hispanic. That's supposed to be $14,000. And then when you go to you start thinking about the research culture and underrepresented minorities. If you think about the faculty level, 3.5% of faculty in life science, and then 6.3% in basic science departments. And so as Dr. Ayisi was talking about, it being in STEM and even, coming from areas, even when you have a background of people who have been in STEM that you're following or your parents or things like that, it still can be a challenge, And so just imagine if you didn't know about education, you didn't even know STEM existed. So you see those numbers, that data there. Women is about 39% to 35%, and that's faculty in life science versus basic science. So only about 27% of women publish in STEM fields in the last 60 years. That is such a shocking percentage. It's estimated that 34% of women in tech and about 43% in STEM, and then 30% in science worldwide. Then I go back up to the Google and Gallup particular research. Why are we seeing numbers like this? One of the reasons, and I'll talk a little more about this in a moment, is how female students, we think about how they are less likely than males to be aware of even areas like computer science. I know that's changing a little bit with, social media and things like that, but there is still such a big thing, they are learning about opportunities on the internet and the community, but and that they're interested in learning and things like that. But only about 11% of females reported seeing people doing computer science, and even less people like them doing computer science. And so not even seeing females. And so you can just imagine, compared to males, they were likely to be told by parents or teachers that they will be good at computer science. So 46% of males were told they will be good at computer science versus 27% by the parent, and then 39% versus 26% by the teacher. And so more parents lacked interest in computer science as a major, especially among females. And we see that impact on female and racial ethnic minorities. So you could just imagine the almost like tracking of students into certain areas. So Black students were less likely than white to have classes dedicated to computer science, so 47 versus 58%. And then even less likely to use a computer at home. And you can see those numbers, and even with Hispanic being 50%. And so not even realizing or having that exposure or even getting encouraged to go into areas like so we can think about, like I was saying, with the female socialization, and so this idea of how you obtain your knowledge, your language, your social skills, even the values to comply to the social norms. And so we think about how females, there's this idea that females should focus on soft science and not technical, or Blacks should be athletes and not think about education or not go that educational track. You see that, go that social or that liberal arts or that track instead of trying to do STEM field type of things. So we see that kind of socialization in school. We see that in homes. So we really need this idea of a resocialization where we change how we think about these different areas. Create a new culture of how we affect health and science and how we go into thinking about how our data should look like. We want our data to look like us. We want our scientists to look like us. So we need to be the change and create that change within the people coming behind us. going to the comment, and I think even Dr. Adisi talked about this, that nobody looks like me. I just did a simple Google search of what scientists, of the word scientist, and this is what came up. And it is good to see that there is a person of color on there. There is at least a woman on there, a woman and two. So it is changing in society. And so re-socializing what it looks like in these areas is going to be a big deal for changing that. Let's see, let me move along. So my health data file story just quickly was about the adoption of telehealth and how consumer health adoption rates, and that consumer health just meaning how people were empowered to take control of their particular health. And so you saw the data shows that about 17% of people during the COVID-19 pandemic really took telehealth. And so they were able to see their doctor via online, via their phone, things like that. So you saw this major increase of about 11% of just adopting, getting on their patient portals and checking out different areas that affect their health. Trying to hurry up. So this last part, thinking about how can we empower ourselves. I had the opportunity to meet Dr. Ronald Lorenzo at Prairie View A&M University, who introduced me to a program called Eterna. And Eterna is a game which is community science. And so it takes this principle of community science to basically change how we are controlling our narrative and controlling or empowering ourselves to create health and create data for bettering our health. But community science, just as a quick definition, is a scientific research and monitoring based on scientific modes of inquiry, and which are basically community-driven, community-controlled, community-led, and really about this social collective learning and empowerment. It has these, basically it takes, we know traditional science in the community, that's the scientific community going to the community. Citizen science kind of takes that a step further, where we are actually have the citizens involved with the science as we go along. And then community science, even more, the community really controls how that science goes. And some of the benefits we're seeing that is it really does balance the bias. It facilitates specialization, encourages diversity, innovation of thought, invigorates problem solving, and even represents the society because it is the society actually being involved. So like I said, one example is the Eterna game. And Dr. Riju Das is actually one of the creators for this, and he has a whole team of wonderful researchers who are actively doing that, as well as the players. The players are involved from the beginning process. And this particular game, it looks like a video game because it is, and it actually takes the players are able to create science in their own way. They're able to design it, they're able to analyze it, they even test the results in the lab. Eterna has over 10 years. I'm just going to skip right through just so I have a few minutes for questions. But basically, players solve this problem. They get feedback on this. They even are involved in writing papers and inventing medicine. With Eterna, the video, the players design the RNA. They're able to vote on which sequence, which puzzle works, and then those particular things, the one that rate the best, they actually synthesize those and use the in the lab to create experiments and things like that. And then those results are put out, either retested or redesigned with the players, or they actually, a lot of them go to publication. There's over 250,000 registered players, and there's over 25 scientific publications. And these are actually, this is very unique because these publications are written by the players themselves. They are actively involved in the development and the dissemination of the science that they participate in. One recent one came out in Nature Communications, and this is by the players. And so it's always a wonderful thing to see this particular science happen this way. Oops. Slides froze. Hold on. I had a video, but I'm gonna skip that. But if you get a chance to check out Eterna, this is Das Lab and everything at Stanford University and people involved, as well as if you want to learn more specifically about this community science program. As an example, I wanted to give you this as a way to empower ourselves to get involved in community science, and that is one way we can change how our health data is being formulated and how we're affecting the health in our communities. And that's all I have. Thank you so much.
Thank you so much, Dr. Williams. That's actually quite fascinating. Wow, so the Eternate game has 25,000 players? Is that what you said? They have 25,000?
250,000.
250,000. Okay, I'm an order of magnitude off. Oh my goodness. Okay. Somewhere my data scientist husband is like clucking his tongue at me. Wow, that's really amazing. As somebody who's worked in sort of educational technology most of my, that's a big win. That's really remarkable. So I'm trying to sort of wrap my head around all of this. So the thing that you're talking about with the participatory research, community research, it sounds similar to some of the models that we try to promote, right? We talk a lot about trying to, as data scientists, be part of community participatory action research, where we kind of provide kind of the way Dr. Williams, or Dr. Davis rather, was talking about it. So I guess my question is, for those of us who have sort of a data science background and who are really trying to commit to this space, right, and kind of be part of this, do you see some obvious places or methods that we can use to bring those skills to the table, but be part of this community research kind of model that you're talking about? Like, what would you recommend for a bunch of math nerds like us, and how we can sort of best help?
For sure. I think one way is to get involved with these kind of communities pushing forward this idea of community science. So, for example, getting involved with Eterna, being a player, as well as being involved with the development and pushing that forward. I know that lab is welcoming to that. Another thing I think is the exposure of younger generations and making sure they know that option is there. I think I'm in informatics, but I didn't even hear about informatics until like my first year of my doctorate program, and so how I think about how much further I probably could be in it if I had known about it a little bit earlier, and so just taking those opportunities as well to go to some of those younger generations and getting maybe in schools and finding that area just to talk to them about it, bringing it up so that they know that it's available. I think that is another way.